Image inclusion body myositis, IBM. Inclusion body myositis, IBM, is the most common acquired inflammatory myopathy in individuals older than 50 years. It is a slowly progressive muscle disease characterized by a combination of inflammatory and degenerative changes in skeletal muscle. Key features usually affects individuals above 50 years of age, more common in males. Progression is typically slow, occurring over years. Weakness is often asymmetric, unlike many other myopathies. Characteristic pattern of weakness. The hallmark of IBM is selective involvement of quadriceps muscles, difficulty climbing stairs, frequent falls, difficulty rising from a chair, finger flexors, weak grip strength, difficulty opening bottles or turning keys, wrist flexors, ankle dorsiflexors may also be involved later. Facial muscles are usually spared, although mild facial weakness may occur. Bulbar involvement. Dysphagia occurs in approximately 40 to 60% of patients, may lead to choking or aspiration. Examination findings. Muscle wasting, particularly of quadriceps and forearm flexors. Weakness is often asymmetrical. Reflexes may be preserved initially but can decrease with severe weakness. Sensory examination is typically normal. Investigations. Serum creatine kinase CK, normal or mildly elevated, usually less than 10 times the upper limit of normal. Electromyography, EMG, shows a mixed pattern of myopathic motor unit potentials, fibrillation potentials, occasionally neurogenic features. MRI muscle demonstrates selective muscle involvement and fatty replacement. Muscle biopsy, diagnostic. Characteristic findings include endomesial inflammation, invasion of non-necrotic muscle fibers by CD8 plus T lymphocytes, rimmed vacuoles, intracellular protein aggregates, amyloid deposits may be present. Diagnostic criteria. The diagnosis is based on 1, age usually more than 45 years, 2, slowly progressive weakness for more than 12 months, 3, finger flexor weakness greater than shoulder abductor weakness, 4, quadriceps weakness greater than hip flexor weakness. 5, characteristic muscle biopsy findings. Differential diagnosis, polymyositis, dermatomyositis, amyotrophic lateral sclerosis, ALS, motor neuron disease, muscular dystrophies, chronic inflammatory demyelinating polyneuropathy, CIDP. Treatment. IBM responds poorly to immunotherapy, physiotherapy and exercise programs, fall prevention strategies, management of dysphagia, assistive devices when needed. Therapies such as corticosteroids, azathioprine, methotrexate, and IVIG generally show limited benefit. Prognosis, slowly progressive disease. Many patients require walking aids after several years. Life expectancy is usually near normal, although complications from falls and aspiration can occur. Classic examination, pearl asymmetric weakness involving the quadriceps and deep finger flexors in an elderly patient is highly suggestive of inclusion body myositis. Differential diagnosis of inclusion body myositis, IBM, and their differentiation. Polymyositis. Polymyositis is the most important differential diagnosis of IBM because both conditions present with proximal muscle weakness and elevated creatine kinase levels. Polymyositis usually affects younger individuals between 30 and 60 years of age and causes symmetrical proximal muscle weakness involving shoulder and hip girdle muscles. Finger flexor and quadriceps predominant weakness are uncommon. Serum CK levels are often markedly elevated, and patients generally respond well to corticosteroids and immunosuppressive therapy. Muscle biopsy in polymyositis shows endomesial inflammation, but lacks rimmed vacuoles and protein aggregates that are characteristic of IBM. Dermatomyositis. Dermatomyositis presents with symmetrical proximal muscle weakness similar to polymyositis, but is distinguished by characteristic skin manifestations such as heliotrope rash, Gottron papules, Schall sign, and V sign. Dysphagia may occur in both conditions, but selective weakness of finger flexors and quadriceps is unusual in dermatomyositis. Muscle biopsy shows perivascular atrophy and perivascular inflammation rather than endomesial inflammation with rimmed vacuoles seen in IBM. Amyotrophic lateral sclerosis, ALS. Amyotrophic lateral sclerosis may resemble IBM because both can present with asymmetric weakness and muscle wasting. However, ALS is characterized by upper motor neuron signs such as spasticity and hyperreflexia, along with lower motor neuron signs including fasciculations and widespread denervation. Sensory examination remains normal in both disorders. EMG in ALS shows widespread neurogenic changes without myopathic features, whereas IBM demonstrates predominantly myopathic changes with inflammatory features on biopsy. Primary lateral sclerosis. Primary lateral sclerosis can occasionally be confused with IBM in patients presenting with gait difficulty and falls. However, PLS produces spasticity, hyperreflexia, extensor plantar responses, and upper motor neuron weakness without muscle atrophy or elevated CK levels. IBM causes muscle wasting, especially involving quadriceps and finger flexors, and lacks upper motor neuron signs. Limb girdle muscular dystrophy. Limb girdle muscular dystrophies usually present with slowly progressive proximal muscle weakness involving pelvic and shoulder girdle muscles and may resemble IBM clinically. However, these disorders often begin earlier in life and have a positive family history. Finger flexor weakness and marked asymmetry are less common. Genetic testing and muscle biopsy demonstrating dystrophic changes without rimmed vacuoles help distinguish these disorders from IBM. Facioscapulohumeral muscular dystrophy. Facioscapulohumeral muscular dystrophy may produce asymmetric weakness similar to IBM. However, facial weakness, scapular winging, and shoulder girdle involvement predominate in facioscapulohumeral muscular dystrophy, whereas IBM preferentially affects finger flexors and quadriceps. The younger age of onset and positive family history further support the diagnosis of facioscapulohumeral muscular dystrophy. Oculopharyngeal muscular dystrophy. Oculopharyngeal muscular dystrophy may resemble IBM because both conditions can present in older adults with dysphagia. However, ptosis and ophthalmoplegia are common in oculopharyngeal muscular dystrophy, but are unusual in IBM. Genetic testing confirms the diagnosis. Myasthenia gravis. Myasthenia gravis can present with dysphagia and limb weakness, occasionally leading to confusion with IBM. The weakness in myasthenia gravis fluctuates and worsens with exertion, whereas IBM causes fixed progressive weakness. Ocular symptoms such as ptosis and diplopia are common in myasthenia gravis but rare in IBM. CK levels and muscle biopsy are usually normal in myasthenia gravis. Chronic inflammatory demyelinating polyneuropathy, CIDP. Chronic inflammatory demyelinating polyneuropathy may present with weakness and gait difficulty. However, CIDP is usually associated with sensory symptoms, areflexia, and nerve conduction studies showing demyelination. IBM typically has preserved sensation and shows myopathic rather than neuropathic findings on electrophysiological studies. Statin-associated immune-mediated necrotizing myopathy. This condition presents with proximal muscle weakness and markedly elevated CK levels in patients exposed to statins. Unlike IBM, weakness is usually symmetrical and predominantly proximal without selective finger flexor involvement. Muscle biopsy reveals necrotizing myopathy with minimal inflammation and lax rimmed vacuoles. Anti-HMG-CoA reductase antibodies are often positive, and patients generally respond to immunotherapy. Clinical pearl. The combination of slowly progressive asymmetric weakness affecting the quadriceps and deep finger flexors in a patient older than 50 years, together with poor response to immunotherapy and the presence of rimmed vacuoles on muscle biopsy, strongly favors inclusion body myositis over its mimics. Hashtag. Serological diagnosis of inclusion body myositis, IBM. Unlike many other inflammatory myopathies, inclusion body myositis does not have a highly sensitive or specific serological marker, and the diagnosis remains primarily clinical and pathological. The most important antibody associated with IBM is the anti-cytosolic 5-nucleotidase 1A anti-CN1A antibody, also known as the anti-NT5C1A antibody. This antibody is detected in approximately 30 to 70% of patients with IBM and has a specificity of approximately 80 to 90%. The presence of anti-CN1A antibodies strongly supports the diagnosis in an appropriate clinical setting, especially in patients with characteristic quadriceps and finger flexor weakness. However, its absence does not exclude IBM because a substantial proportion of patients are seronegative. Anti-CN1A antibodies may also be detected in other autoimmune diseases such as systemic lupus erythematosus Sjögren's syndrome and occasionally in other inflammatory myopathies, which limits their diagnostic specificity. Serum creatine kinase, CK, levels are usually normal or mildly elevated, and are typically less than 10 times the upper limit of normal. Values are commonly in the range of 300 to 1500 IU per LR. Markedly elevated CK levels above this range should prompt consideration of alternative diagnoses, such as immune-mediated necrotizing myopathy or muscular dystrophy. Routine myositis-specific antibodies such as anti-JO1, anti-SRP, anti-MI2, anti-MDA5, anti-1-GONG, anti-NXP2, and anti-HMGCR are usually negative in IBM. Their presence suggests an alternative inflammatory myopathy rather than IBM. How to diagnose inclusion body myositis. The diagnosis of IBM is based on a combination of clinical features, laboratory findings, electrophysiological studies, imaging, and muscle biopsy. The first step is recognition of the characteristic clinical phenotype. IBM should be suspected in a patient older than 45 to 50 years who presents with slowly progressive weakness over several years, particularly when weakness is asymmetric and selectively involves the quadriceps muscles and deep finger flexors. Patients commonly report difficulty climbing stairs, rising from a chair, frequent falls, and impaired grip strength. Dysphagia is also common and may be an early feature. Laboratory evaluation typically reveals normal or mildly elevated CK levels. The presence of anti-CN1A antibodies can support the diagnosis but is not required. Electromyography usually demonstrates a mixed myopathic and neurogenic pattern with short duration, low amplitude motor unit potentials, fibrillation potentials, positive sharp waves, and occasionally large motor units. These neurogenic features may lead to confusion with motor neuron disease. Muscle MRI may show selective fatty infiltration and atrophy, particularly involving the quadriceps, flexor digitorum profundus, medial gastrocnemius, and other characteristic muscle groups. MRI can also help identify an appropriate site for biopsy. The definitive diagnosis is established by muscle biopsy. The characteristic pathological features include endomesial inflammatory infiltrates predominantly composed of CD8 plus T lymphocytes, invasion of non-necrotic muscle fibers by inflammatory cells, rimmed vacuoles, intracellular protein aggregates containing amyloid, P62, TDP43, and ubiquitin. Mitochondrial abnormalities such as cytochrome oxidase negative fibers. Diagnostic criteria. The widely used criteria are the 2011 European Neuromuscular Center (ENMC) criteria. According to these criteria, the diagnosis is based on mandatory clinical features, age of onset greater than 45 years, duration of symptoms greater than 12 months, CK level less than 15 times the upper limit of normal. Sheshtar. Characteristic clinical features, weakness of finger flexors greater than shoulder abductors, weakness of quadriceps greater than hip flexors. Pathological features, endomysial inflammation, rimmed vacuoles, protein accumulation or 15 to 18 nanometer filaments, upregulation of MHC class 1 molecules. Depending on the combination of clinical and pathological findings, patients are classified as clinico-pathologically defined IBM, clinically defined IBM, or probable IBM. Practical diagnostic approach. In a patient older than 50 years with slowly progressive asymmetric weakness predominantly affecting the quadriceps and finger flexors, obtain CK levels and anti-CN1A antibodies, followed by EMG and muscle MRI. If the clinical suspicion remains high, perform a muscle biopsy from an affected but not end-stage muscle. The demonstration of endomysial inflammation with rimmed vacuoles confirms the diagnosis. Diagnostic Pearl. A patient older than 50 years with difficulty climbing stairs, repeated falls, weak hand grip due to finger flexor weakness, mildly elevated CK, poor response to corticosteroids, and rimmed vacuoles on muscle biopsy should be considered to have inclusion body myositis until proven otherwise.